Flexibility and muscle length testing. During the initial assessments of posture and movement, a personal trainer may opt to assess the flexibility of specific muscle groups that he or she suspects demonstrate tightness or limitations to movement. While figures 7 Tack 33 and 7 Tack 34 illustrate normal ranges of motion for healthy adults at each major joint, specific muscle groups that frequently demonstrate tightness or limitations to movement are discussed in this section. In addition, Table 7 Tack 13 present the average range of motion at various joints for healthy adults. Figure 7 Tack 35 can be used to keep records when conducting the flexibility assessments presented in this section. Average range of motion for healthy adults, Table 7, Tack 13. Joint and movement, shoulder/scapulae. Flexion, 150 to 180 degrees. Extension, 50 to 60 degrees. Abduction, 180 degrees. Internal or medial rotation, 70 to 80 degrees. External or lateral rotation, 90 degrees. Shoulder horizontal adduction or adduction, 90 degrees. Shoulder horizontal abduction or abduction, 30 to 40 degrees. Elbow flexion, 145 degrees. Elbow extension, 0 degrees. Radial ulnar pronation, 90 degrees. Radial ulnar supination, 90 degrees. Wrist flexion, 80 degrees. Wrist extension, 70 degrees. Wrist radial deviation, 20 degrees. Wrist ulnar deviation, 45 degrees. Cervical spine flexion, 45 to 50 degrees. Cervical spine extension, 45 to 75 degrees. Cervical spine lateral flexion, 45 degrees. Cervical spine rotation, 65 to 75 degrees. Thoracolumbar spine, lumbar flexion, 40 to 50 degrees. Sorry, that was wrong. Lumbar flexion, 40 to 45 degrees. Thoracic flexion, 30 to 40 degrees. Lumbar extension, 30 to 40 degrees. Thoracic extension, 20 to 30 degrees. Lumbar rotation, 10 to 15 degrees. Thoracic rotation, 35 degrees. Lumbar lateral flexion, 20 degrees. Thoracic lateral flexion, 20 to 25 degrees. Hip flexion, 100 to 120 degrees. Hip extension, 10 to 30 degrees. Hip abduction, 40 to 45 degrees. Hip adduction, 20 to 30 degrees. Internal or medial rotation, 35 to 45 degrees. External or lateral rotation, 45 to 60 degrees. Knee flexion, 125 to 145 degrees. Knee extension, 0 to 10 degrees. Ankle dorsiflexion, 20 degrees. Ankle plantar flexion, 45 to 50 degrees. Subtalar inversion, 30 to 35 degrees. Subtalar eversion, 15 to 20 degrees. Thomas test for hip flexion and quadriceps length. Objective: to assess the length of the muscles involved in hip flexion. This test can actually assess the length of the primary hip flexors. Hip flexors or iliopsoas, rectus femoris, one of the 4 quadriceps muscles. This test should not be conducted on clients suffering from low back pain unless cleared by their physician. Equipment: stable table. Instructions: given the nature of the movement associated with this test, trainers may want to consider draping a towel over the client's groin area. Explain the objective of the test and allow a warm-up. Instruct the client to sit at the end of a table with the mid-thigh aligned with the table edge. Place one hand behind the client's back and the other under his or her thighs. While supporting the client, instruct him or her to gently flex both thighs toward the chest and gradually assist as the client rolls back onto the table to touch the back and the shoulders to the tabletop. Instruct the client to slowly pull one thigh toward the chest, reaching with both hands to grasp the thigh or the area behind the knee without raising or moving the torso. Ask the client to slowly relax the opposite leg, allowing the knee to slowly fall toward the table and the lower leg to hang freely off the table edge. A 1 inch or 2.5 centimeter spacing between the back of the knee and the table edge is adequate. Observations. Observe whether the back of the lowered thigh touches the table, hips positioned in 10 degrees of extension. Observe whether the knee of the lower leg achieves 80 degrees of flexion. Observe whether the knee remains aligned straight or falls into internal or external rotation. General interpretations. Use the information provided in Table 7 Tack 1.4 to determine the location and identity of the tight or limiting muscles. Table 7 Tack 1.4 Interpretation of the Thomas Test. Movement/limitation. With the back and sacrum flat, the back of the lowered thigh does not touch the table and the knee does not flex to 80 degrees. Suspected muscle tightness, primary hip flexor muscles. With the back and the sacrum flat, the back of the lowered thigh does not touch the table, but the knee does flex to 80 degrees. The suspected muscle tightness is of the iliopsoas, which is preventing the hip from rotating posteriorly and inhibiting the thigh from being able to touch the table. With the back and the sacrum flat, the back of the lowered thigh does touch the table, but the knee does not flex to 80 degrees. The suspected muscle tightness is of the rectus femoris, which does not allow the knee to bend. Passive straight leg raise. Objective: to assess the length of the hamstrings. Equipment: a stable table or an exercise mat. Instructions: explain the objective of the test and allow a warm-up. Instruct the client to lie supine on a mat or table with the legs extended and the low back and sacrum flat against the surface. Place one hand under the calf of the leg that will be raised while instructing the client to keep the opposite leg extended on the mat or table. Restrain that leg from moving or rising during the test. Slide the other hand under the lumbar spine into the space between the client's back and the mat or the table. Advise the client to gently plantar flex his or her ankles to point the toes away from the body. This position avoids a test limitation due to a tight gastrocnemius muscle, which would limit knee extension and with the ankle and dorsiflexion. I'll read that again. Advise the client to gently plantar flex his or her ankles to point the toes away from the body. This position avoids a test limitation due to a tight gastrocnemius muscle, which would limit knee extension with the ankle and dorsiflexion. Additionally, a straight leg raise with dorsiflexion may increase tension within the sciatic nerve and create some discomfort. Slowly raise the one leg, asking the client to keep that knee loosely extended throughout the movement. Continue to raise the leg until firm pressure can be felt from the low back pressing down against the hand. This indicates an end range of motion of the hamstrings, with movement now occurring at the pelvis, which is rotating posteriorly. Throughout the movement, the client needs to maintain extension in the opposite leg and keep the sacrum and low back flat against the mat or table. If the test is performed with the opposite hip in slight flexion, this allows the pelvis more freedom to move into a posterior tilt, allowing a greater range of motion and falsely increasing the length of the hamstrings. Observation: Note the degree of movement attained from the table or mat that is achieved before the spine compresses the hand under the low back or the opposite leg begins to show visible signs of lifting off the table or mat. The mat or table represents 0 degrees. The leg perpendicular to the mat or table represents 90 degrees. General interpretation. Use the information provided in Table 7, Tack 1.5 to determine the limitations. Interpretation of the passive straight leg raise. Movement or limitation. The raised leg achieves greater than or equal to 80 degrees of movement before the pelvis rotates posteriorly. This indicates that the hamstring's length is a normal hamstring length. Movement or limitation. The raised leg achieves less than 80 degrees of movement before the pelvis rotates posteriorly or there are any visible signs in the opposite leg lifting off the mat or table. This indicates that the hamstrings are tight. Shoulder mobility. Apley's scratch test involves multiple and simultaneous movements of the scapulothoracic and glenohumeral joints in all 3 planes. This represents a challenge in evaluating shoulder movement and identifying movement limitations. To identify the source of the limitation, trainers can first perform various isolated movements in single planes to locate potentially problematic movements. Consequently, the scratch test is completed in conjunction with the shoulder flexion extension test and an internal and external rotation test of the humerus. Shoulder flexion and extension. Objective: to assess the degree of shoulder flexion and extension. This test should be performed in conjunction with Apley's scratch test to determine if the limitation occurs with the shoulder flexion or extension. The equipment you need is an exercise mat and a pillow, which is optional. Instructions. Explain the purpose of the test. Shoulder flexion. Instruct the client to lie supine on a mat with the back flat and the knee bent and a bent knee position. Knees and second toes aligned with the ASIS and with the arms at the sides. Have the client engage the abdominal muscles to hold a neutral spine without raising the hips from the mat. Instruct the client to raise both arms simultaneously into shoulder flexion, moving them overhead, keeping them close to the sides of the head, and bringing them down to touch the floor or as close to the floor as possible. The client must maintain extended elbows and neutral wrist position. The arms will naturally rotate internally during this movement. Have the client avoid any arching in the low back during the movement. Have the client avoid any depression of the rib cage which may pull the shoulders off the mat. Shoulder extension. Instruct the client to lie prone, extending both legs with arms at the sides and resting the forehead gently against the pillow or the mat. Ask the client to slowly raise both arms simultaneously into extension, lifting them off the mat while keeping the arms close to the sides. The arms will naturally rotate internally during this movement. A small amount of extension in the thoracic spine is acceptable during the movement. The client should avoid any arching in the low back or any rotation of the torso during the movement. The client should avoid any attempts to lift the chest or head off the mat during the movement. Observations. Measure the degree of movement in each direction. Note any bilateral differences between the left and right arms in performing both movements. General interpretations. Use the information provided in Table 7, Tack 1.6 to determine the limitations in these shoulder flexibility tests. Table 7, Tack 1.6, Interpretation of the shoulder flexion and extension. Movement and limitation of flexion. The ability to flex the shoulders to 170 to 180 degrees, hands touching or nearly touching the floor. This indicates good shoulder mobility. The inability to flex the shoulders to 170 degrees or discrepancies between the limbs indicates potential tightness in the pectoralis major and minor, latissimus dorsi, teres major, rhomboids, and subscapularis. Tightness in the latissimus dorsi will force the low back to arch. Tightness of the pectoralis minor may tilt the scapulae forward into an anterior tilt and prevent the arms from touching the floor. Tight abdominals may depress the rib cage, tilting the scapulae forward into an anterior tilt and will prevent the arms from touching the floor. Thoracic kyphosis may round the thoracic spine and prevent the arms from touching the floor. Table 7, Tack 16 continued. Movement and limitation and extension. The ability to extend the shoulders to 50 to 60 degrees off the floor demonstrates good shoulder mobility. An inability to extend the shoulders to 50 degrees or discrepancies between the limbs indicates potential tightness in pectoralis major, abdominals, subscapularis, certain shoulder flexures like the anterior deltoid, the tightness in the coracobrachialis and biceps brachii. Tightness in the abdominals may prevent normal extension of the thoracic spine and rib cage. Tightness in the biceps brachii may prevent adequate shoulder extension with an extended elbow, but may permit extension with a bent elbow. Internal and external rotation of the humerus at the shoulder. To assess internal or medial and external or lateral rotation of the humerus at the shoulder joint, this test should be performed in conjunction with Apley's scratch test to determine if the limitation occurs with internal or external rotation of the humerus. The equipment you need is a mat. Instructions. Explain the purpose of the test. Instruct the client to lie supine with his or her back flat on a mat in a bent knee position, knees and second toe aligned with the ASIS. Ask the client to AB duct the arms to 90 degrees with a 90-degree bend at the elbows and the forearms perpendicular to the mat, i.e. pointing up toward the ceiling. The upper arms must remain aligned with the shoulders throughout the test. The backs of the upper arms should rest against the mat throughout the test. External or lateral rotation to evaluate medial rotators. Ask the client to slowly rotate his or her forearms backward toward the mat, aiming to rest the forearms and the backs of the hands on the mat adjacent to the head while maintaining the 90-degree bend at the elbows. The client should engage the abdominals to avoid arching the low back and avoid flexing the spine forward. The client should maintain a neutral wrist position throughout the movement. Internal or medial rotation to evaluate lateral rotators. Have the client return to the starting position, forearms perpendicular to the mat. Ask the client to slowly rotate the forearms forward toward the mat, turning the palms downward while maintaining 90-degree bend at the elbows. The client should avoid raising the shoulders off the table or flexing the spine forward. The client must maintain a neutral wrist position throughout the movement. Observation. Measure the degree of movement in each direction. Note any bilateral differences between the left and right arms in performing both movements. General interpretation. Use the information provided in Table 7, Tack 17 to determine the limitations in this flexibility test. Interpretation of the external and internal rotation test. External or lateral rotation. The ability to externally rotate the forearms 90 degrees to touch the mat indicates good mobility in the internal or medial rotators, allowing the joint to move through the full range. An inability to reach the floor or discrepancies between the limbs indicates potential tightness in the internal rotators of the arm, i.e. subscapularis. The joint capsule and ligaments may also be tight and limit rotation. Internal medial rotation. The ability to internally rotate the forearm 70 degrees toward the mat, i.e. forearms are 20 degrees off the mat, indicates good mobility in the external or lateral rotators, allowing the joint to move through the full range. Inability to internally rotate the forearm 70 degrees or discrepancies between the limbs indicates potential tightness in the external rotators of the arm, i.e. the infraspinatus and the teres major. The joint capsule and ligaments may also be tight and limit rotation. Apley's scratch test for shoulder mobility. Objective: to assess simultaneous movements of the shoulder girdle, primarily the scapulothoracic and glenohumeral joints. Movements include shoulder extension and flexion, internal and external rotation of the humerus at the shoulder, scapular abduction and adduction. Instructions: explain the purpose of the test and allow a warm-up, e.g. forward and rearward arm circles. Shoulder flexion, external rotation, and scapular abduction. From a sitting or standing position, the client raises one arm overhead, bending the elbow and rotating the arm outward while reaching behind the head with the palm facing inward to touch the medial border of the contralateral scapula or to reach down the spine, touching the vertebrae as far as possible. The client should avoid any excessive arching in the low back or rotation of the torso during the movement. Have the client repeat the test with the opposite arm. Shoulder extension, internal rotation, and scapular adduction. From a sitting or standing position, the client reaches one arm behind the back, bending the elbow and rotating the arm inward and the palm facing outward to touch the inferior angle of the contralateral scapula or to reach up the spine, touching the vertebrae as far as possible. The client should avoid any excessive arching in the low back or rotation of the torso during the movement. Have the client repeat the test with the opposite arm. Observations. Note the client's ability to touch the medial border of the contralateral scapula or how far down the spine he or she can reach with the shoulder flexion and external rotation. Note the client's ability to touch the opposite inferior angle of the scapula or how far up the spine he or she can reach with the shoulder extension and internal rotation. Observe any bilateral differences between the left and right arms in performing both movements. General interpretations. Use the information provided in Table 7, Tack 1-8 to determine the limitations in this flexibility test. Interpretation of Apley's scratch test. Movement limitation. Ability to touch specific landmarks indicates good shoulder mobility. Inability to reach or touch the specific landmarks or discrepancies between the limbs indicates that further evaluation is required to determine the source of the limitation, i.e. which of the movements is problematic. Shoulder flexion and extension, internal and external rotation of the humerus, or scapular abduction and adduction.